Thank you so much for the introduction. It is a real pleasure for me to be here with you today. As you mentioned, I'm here in San Francisco. The sun has not yet risen. It's a foggy day here in San Francisco. And so you may hear the foghorn blowing in the background. But I am very grateful for the opportunity to be with you today. And on behalf of colleagues here in San Francisco at the University of California and collaborators at UCLA, it's a real pleasure to be able to talk to you on this topic. I will be speaking in three parts, relatively quickly addressing the epidemiology of COVID. Where are we at in terms of the ongoing transmission of the disease, new and emerging variants. And then in the second part, I want to just share with you just a few notable scientific updates that actually give me some optimism in the midst of what feel like fairly gloomy times globally. And then I want to end part three by discussing what lessons we learned from COVID-19 that should inform our public health practice moving forward. Just going to make sure I see the chat. Please let me know if I'm speaking too fast or not fast enough. So part one, let me begin with an update. These are the global statistics for COVID-19 right now. And
Mike, you need to just keep going. Sometimes people unmute and we'll keep muting.
Sure. Yeah, no problem. I think everybody knows how devastating this pandemic has been. There is not a single country on the planet that has been spared the awful impact of SARS-CoV-2. And as of last week, the global reports are that there have been 5.8 million deaths and over 426 million people who have been infected with COVID-19. And with the latest surge in disease, we've seen, at least in the US, a significant increase in mortality from the disease. As to whether this number, 5.8 million, is a true estimate of the impact of mortality, I think there is some debate. And I've included here on the right of the screen some estimates that have been published in peer-reviewed journals suggesting that maybe the true burden of disease in terms of COVID mortality could be closer to 13 million and maybe as high as 22 million. These numbers are huge and they dwarf the number of deaths from the 1968 or the 1957 flu pandemic. So just to give you some sense of how devastating COVID has been, but I'm sure you already know that. I'm sure also that you're aware of the epidemiology of COVID in Armenia. As of yesterday, the WHO reporting a total of 420,000 cases and estimates of about 8,000 deaths reported from SARS-CoV-2. Hopefully, as the epidemiological curve illustrates here, we are seeing a decrease in both incidence and mortality in recent days here in Armenia. So have we seen the end of COVID? Certainly, are we at the end of this recent surge in cases from Omicron? Well, as these graphs clearly illustrate, we are seeing a significant decline in the number of cases worldwide. These graphs are from the New York Times newspaper. And as evidence of the fact that we are seeing a decrease in cases, many countries are lifting their restrictions that had been imposed earlier in the pandemic. So the United Kingdom have ended all remaining restrictions controlling movement related to COVID-19. And across the European Union, all 27 nations have now said that people can travel freely if they are vaccinated. Evidence again of the fact that maybe we are seeing the end of the pandemic. However, I don't think the pandemic is over for everybody. And I just highlighted here that there are still ongoing outbreaks. In fact, in Hong Kong right now, they're seeing their worst COVID outbreak. And they're about to test 7 million residents in Hong Kong as evidence of increased transmission there. And in Iceland, a country that has been spared the worst of the pandemic up until now, they've recently seen nearly a 50% increase in cases. My point is that there are hotspots that continue to have ongoing transmission. What about COVID-19 global coverage? Well, a key determinant of declining cases has been increasing global coverage with vaccines. And I think it's fair to say that we have witnessed an amazing feat, not just of scientific discovery, but of programmatic industry. Nearly 5 billion people around the globe have received at least one dose. And again, you may be familiar with the data from Armenia. As of 2 days ago, more than 2 million Armenians have received at least one COVID-19 vaccine. And that's around 54%, and around 46% of eligible citizens have received both doses. They're fully vaccinated, with a smaller number, 23,000, having also received the booster. However, as we zoom out and look at the global coverage, profound inequities still exist. And I draw your attention to Africa, where they have still not been able to enable widespread coverage of life-saving vaccines. So I want to speak about the variant that is most relevant to our practice, our public health practice right now, which is the Omicron variant, the predominant strain around the world now. And as you know, this variant spread like wildfire across the globe, including in Armenia, and was first detected in South Africa in October. And what have we learned about this variant, and how is it different from earlier variants of COVID-19? Well, I'll share the data in a second that demonstrates that it's more transmissible. It causes less severe disease, maybe. Its incubation period is shorter. But, and importantly, and a point I'll dwell on, boosters make all the difference. Before I do share those data, though, let me just apprise you of some of the important characteristics of the virus. And part of the reason why, even right from the first detection of Omicron, there was so much concern was because from a molecular point of view, scientists realized that this strain was remarkably, significantly different from earlier strains of COVID-19, insofar as Omicron carried 50 new mutations that had not been seen in combination before, including 30 mutations on the spike protein. The spike protein is the part of the virus that clamps onto the host cells. And because of those mutations, there was concern as soon as it was detected that this would be a variant that could cause a different kind of disease. And turns out that mostly that's a more mild form of disease, but could also evade the host immune system more effectively. And because of the changes in the spike protein, could be transmitted more quickly. Interestingly, there are a couple of genetic deletions, which mean that Omicron looks different on the PCR test, the molecular test that we use. And we've used this to our advantage because it means that from a detection point of view, we were able to see quite early on that even though it was being detected by the existing tests, it looked different, and that allowed us to distinguish it from earlier variants, including Delta. So let me now answer the question, how transmissible is it, and what do we know about the transmission of Omicron and how it's different? Well, this is data that was published this last week in a US medical journal that demonstrates that Omicron is incredibly transmissible, especially to household occupants. There's actually been a lot of studies looking at this, and I want to highlight this study that was done in the United States in 4 different parts of the United States: Chicago, Connecticut, Milwaukee, Wisconsin, and Utah. And they looked at Omicron transmission in household members. And the things that I want to draw your attention to are that the secondary attack rate, so the number of people that were infected in the household from an individual index case was incredibly high, 52%. So more than half of household members that were exposed to a household member who had COVID would go on to develop COVID themselves. This is much higher than we saw with with Delta or prior variants. And a couple of other things that the study illustrated. One was that when household members were vaccinated, that risk of onward transmission was lower. And when the individual with COVID was wearing a mask in the house, the transmission was much lower. But the key message here is that compared to earlier variants, household transmission happened far more frequently. We also learned that this variant moves faster as a consequence of having a shorter incubation period. So that time between initial infection and development of symptoms, the incubation period, as we call it in England, is shorter. And this was documented very early on, back in December, in the academic press, based off of a report from Oslo, Norway, where researchers looked at an outbreak of Omicron that developed in a group of partygoers, an office party who participated in a Christmas party, and many of whom subsequently fell ill from Omicron. Most of them had been vaccinated. And the key thing I wanted to highlight here was that we learned from that case study that Omicron had a shorter incubation period, around 3 to 4 days, which was considerably shorter than the earlier variants, including Delta, which typically has an incubation period of 4 to 5 days. So the next thing we learned about Omicron was that actually it seems to present with less severe disease. I will pause and give some more detail on this particular topic in a second. But what this study showed was that individuals who were infected with Omicron and presented to a hospital system in Southern California were much less likely to develop severe disease and or require hospital admission and or end up in the intensive care unit if they got Omicron, to a similar cohort of individuals who'd been infected with Delta, the Delta variant, a month earlier. And what these 4 different plots show is that compared to the Delta variant, individuals in this hospital system in Southern California were much less likely to get hospitalized with symptomatic disease. And the green here is the individuals with Omicron. The purple are those with Delta. They were much less likely to end up in the ICU, less likely to require ventilation, and less likely to die. So I think a key message here is that in the Omicron surge in Southern California in the US, COVID infections were associated with substantially lower disease morbidity and mortality. As I mentioned, I'll come back to this in a second because that's half the story. The other half of the story is that even in spite of the fact that the disease causes less severe disease, because it's more transmissible, more people have been infected with Omicron. And as a consequence, those individuals that aren't vaccinated have still gone on to develop symptoms, and many have passed away from Omicron. In fact, the numbers are higher by virtue of the fact that more people have gotten infected as compared to earlier variants. However, around the world, what the data seems to show is what has now been referred to, I hope this translates into Armenian, a decoupling, an unlinking of new cases from new deaths. And I'll explain that in a second. I want to pause and reflect on this data from South Africa. I mentioned before that Omicron was first detected in South Africa. It was actually detected quite early on, and they saw a really big increase in cases of Omicron, and the trend upwards was much higher, as was shown in this newspaper article back in October. They also saw a big increase in the amount of COVID that was detected in the wastewater, the sewage water in South Africa, which alerted the public health department that they were dealing with a much severer disease, a much more transmissible disease than they'd seen earlier. So an increase in COVID in the wastewater, an increase in overall cases. But interestingly, and this data was just published this week in the New England Journal of Medicine, despite an increase in cases, they have not seen in South Africa an increase in hospitalizations. And the authors speak to the fact that there has been a decoupling, a delinking of the number of cases from mortality. And that's been true in many parts of the world. However, that's not true everywhere. And in fact, one of the things that has been most apparent in the era of Omicron is that individuals that are fully vaccinated were much less likely to get severe disease. But importantly, individuals that received the booster vaccine, the third dose, 6 months after the initial series, were much, much less likely to develop severe disease. And so on the left of the screen, I highlight data from the Public Health Department in England that demonstrated back in December that the viral efficacy, VE here, the viral efficacy of the vaccines against symptomatic disease was quite significant for Omicron. But importantly, individuals that had received the booster vaccine were much less likely to be hospitalized than those that had not received the booster. This has been confirmed by data in Switzerland, where they've been able to demonstrate very elegantly that the mortality related to Omicron is 9 times lower amongst individuals that had been vaccinated. But the mortality from Omicron amongst people that have received the booster was 48 times lower. A remarkable reduction in mortality, a reflection of the boosting effect in protecting against the worst outcomes of COVID-19. Somewhat more somber reflection of the data from the US on the right of your screen illustrates the fact that actually mortality from Omicron in the United States has been remarkably, depressingly high, at least when compared to many other countries. And the consensus is that the reason why we've seen high mortality from Omicron in the US reflects low uptake of the vaccine generally in the general population, but specifically low uptake of the booster amongst eligible people in the US. And as a consequence, we've seen higher death rates from Omicron than almost any other high-income country. So what's next? I said earlier that I think we're seeing the end of the current surge, and I think there are reasons to be optimistic about that. However, I think there remains the likelihood that there may be new variants on the horizon, and since we've named all of the variants with Greek letters, I think there is no reason to presume that we won't see a new variant, pi, rho, sigma, tau. We may well be using more Greek letters to describe new variants in the future. And to be honest, there's nothing that will preclude a new, more transmissible strain developing. I mean, it's hard to imagine that there could be a more transmissible strain than Omicron, but nonetheless, I think from a biological point of view, we haven't done anything to this virus that would prevent it from mutating again and causing more disease. I include here one sobering piece of data here, which is a plot from a laboratory study looking at whether people who had been exposed to Omicron would be immune to earlier variants. If you were infected with Omicron, would you be immune against Delta or Beta or Alpha? And what this study seemed to suggest was that, and the data has not been published, it hasn't been peer reviewed yet, but it does seem to suggest that the Omicron variant, immunity against the Omicron variant does not protect against the other variants. And I think we need more data to understand what this might mean. But certainly it suggests for me that just because you got Omicron doesn't mean you couldn't get another variant in the future. I'm happy to pause and talk about this at a later point. But in the interest of time, let me now transition to a more optimistic reflection on the science that is emerging and why we should have grounds for optimism that maybe we are seeing the end of this awful pandemic. So I want to start with some data that highlights how the vaccines that are currently available are safe and effective in children. And specifically, the vaccine that has been approved for children in the United States and elsewhere around the planet is the Pfizer vaccine. This is an mRNA vaccine. And I highlight here for you the data from that was published in a premier medical journal, the New England Medical Journal, and that highlights specifically that the vaccine was incredibly safe in children. This is a big issue because parents are always anxious about giving vaccines to their children. They found in this study no adverse events associated with the Pfizer vaccine, and they also demonstrated that it was very effective, 90% effective in preventing transmission. However, we know that children don't seem to be the drivers of this pandemic in the same way that influenza is driven by transmission amongst children. So does it matter? Do we need to vaccinate children? Well, actually, there is modeling data that shows that it's much better to focus our vaccine efforts on vaccinating vulnerable adults, people over the age of 65. But the one important thing about vaccinating children is that if there is a new variant, then this modeling study that was published recently does seem to suggest that vaccinating children is going to be an important way of preventing onward transmission. They call it in the paper the kid effect, the child effect in preventing transmission of new variants, which I think is worth bearing in mind. So vaccines in children, something for us all to be optimistic about, and certainly advocating for children to get vaccines as soon as possible. However, we also know that vaccines alone aren't going to be enough to stop this epidemic. We need to use all sorts of different interventions if we want to end the pandemic. That means, people wearing masks in settings of high transmission. It means contact tracing when we know that we can stop community transmission. And it also means using effective antiviral medications when they're available. And I think one of the really exciting things on the horizon is the development of a couple of new directly active antiviral medications. These are drugs that are specific to COVID-19 and have been demonstrated to be highly efficacious. So two to draw your attention to. One is called Paxlovid. It works by inhibiting one of the enzymes that builds the virus, part of the viral machinery. And then this other drug, molnupiravir, which works by a slightly different mechanism, and was actually developed for treatment of horse encephalitis initially, but has been repurposed to treat COVID. And the most important thing to highlight for you is that Paxlovid in particular has been demonstrated to be incredibly effective. In the trials that the drug companies have run, Paxlovid was seen to lead to nearly a 90% reduction in hospitalization and death, which is incredible. It's an amazing statistic. So there are lots of questions that remain about these drugs. When will they be widely available? Who should be using them and prescribing them? How much will they cost? Can we get them at a cheaper price than the drug companies are trying to sell them at in the US? But I do think that these drugs offer us an alternative, particularly when people aren't vaccinated and need to be treated. And in the US, where there's so much hesitancy about vaccines, these new drugs perhaps add another tool to our toolkit for preventing the worst consequences of this disease. So one final emerging scientific update, and again, I think this is grounds for great optimism and testimony to the brilliance of modern science. Whilst our current vaccines for COVID work very well at preventing severe disease, it's also become apparent that these vaccines have limitations. And so there's been a lot of discussion around how can we ensure that the vaccines are optimally effective and effective against all of the variants and future variants. And in that context, people have been very interested in understanding why some people are able to repel the virus effectively and others aren't. And one of the reasons why some people are able to do that is because they develop these incredibly effective antibodies that are referred to as neutralizing antibodies. And as a consequence of these antibodies, they don't get the severest disease. And so scientists have tried to find these antibodies and determine if they could develop a vaccine that would include the epitopes to those antibodies, as well as to other coronaviruses, broadly neutralizing antibodies against the SARS-CoV strain from 2003, for example. And so in this study that was published this last month in February, researchers from the US demonstrated that a vaccine that included multiple different epitopes to different antibodies for multiple different variants, as well as to SARS-CoV-1, this is the SARS pandemic of 2003, was very effective in preventing the worst disease in mice and in monkeys. And in fact, the study here is the study that was done in monkeys, but there's been a similar study done in mice and another study done in guinea pigs, all of which showing that this pan-coronavirus vaccine is effective. And actually, this is the holy grail from a vaccine point of view, is a pan-coronavirus vaccine that works against all of these variants, as well as past variants and other coronavirus. And whilst the studies are still being done in humans, they're ongoing now, I think this is grounds for real optimism that we may have a pan-coronavirus vaccine coming down the pike soon enough. All right, I need to move. I'm talking too slow. My last section is really on what we've learned from the pandemic today and how we should be thinking about the future. I wonder if you know this US scientist. His name is Tony Fauci. He's a very famous American scientist who's been an advisor to both President Trump and now President Biden. And he wrote a paper actually in 2017 describing how there have been a huge number of emerging infectious disease threats in the last 30 years. In fact, in this paper, and I've included it on the right here, he describes over 34 different emerging infectious disease threats since 1984. Back in 1984, the biggest infectious disease threat was HIV, but since then we've seen Ebola, we've seen chikungunya, we've seen Zika, and now we've seen COVID. And he wrote this very prophetic paper saying, unless we respond, unless the Trump administration responds, we will see another outbreak. And that was in 2017. Sure enough, he was absolutely right. We've now seen the devastating implications of COVID-19. We should have known better. We should have prepared better. And I think one question is, did anybody prepare well? And what can we learn from countries that prepared well for the pandemic? Well, on the right of the screen here, I've included a plot. It's very difficult to read on your screens. I apologize for that. But in the Lancet paper, where researchers looked at 177 countries during the pandemic, the current pandemic, and they looked to see which countries were best prepared for the pandemic in terms of different indicators of pandemic preparedness, availability of masks, access to healthcare, as well as social and political conditions in each of the countries. And what they found was that none of these indicators were predictive of which countries would do well in responding to the pandemic. In fact, the best predictor of lower COVID mortality rates at a country level was trust in the government and social cohesion. So transparency and trust in government. And whilst that conclusion may be a surprise to some of you, it raises an important question. If we're faced with a new pandemic threat tomorrow, a new emerging infectious disease, perhaps a new strain of flu in Indonesia or a new viral hemorrhagic disease in West Africa, would we be any more ready for that than we were for COVID-19? And what can we do to ensure that we are more ready for the next emerging threat? Well, one thing I think we must do around the globe is strengthen surveillance systems. I won't spend too much time on this except to highlight the importance of surveillance systems. In today's interdependent, interconnected world, diseases are able to spread further and faster than ever before. In as little as 36 hours, a pathogen from a remote village in Botswana can spread to all major cities in all 6 continents. And so in that context, it's critical that we have strategies in place to improve detection of new emerging threats. So, and one element of that detection should be using event-based surveillance modalities. And so the team that I work with in San Francisco, we do a lot of time thinking about how can we strengthen surveillance systems, specifically event-based surveillance systems. And these are systems that don't necessarily detect a specific disease, but they detect unusual events that where somebody presents to a clinic with a strange illness or something like that, and these kinds of tools can be very effective at preventing new and emerging threats. The next surveillance tool that I think will be critical in preventing new and emerging infectious disease threats is using genomic surveillance. I wonder whether you're all familiar with genomic diagnostic tests. The WHO has said that these kinds of tests are critical moving forward. And just to give you an example, most diagnostic tests that we use in clinical practice detect specific diseases. So I do a specific test to look for tuberculosis, or I do a specific test to look for measles. Genomic tests work differently. They work on the presumption that we can find any genetic material from any potential organism in a sample, whether that's a sample of sputum or a sample of blood. And these kinds of modalities have been very effective in identifying rare diseases. So I've included here a study from Bangladesh where they use genomic testing to detect chikungunya encephalitis in Bangladesh. They would never have otherwise been able to detect that. However, this kind of testing, some people call it next generation sequencing. Next generation sequencing testing requires two things. It requires that you have laboratory infrastructure where you can do genetic testing, but it also requires that you have bioinformatic capabilities, because when you find genetic material, you won't just find human genetic material or the material from one pathogen. You'll find genetic material from millions of different organisms that are in a single sample of sputum. And so you need very powerful bioinformatic processing ability to filter out the harmless genetic material from the true pathogenic material. And for that reason, you don't just need lab capabilities, you need bioinformatic capabilities. And so there are many groups around the world that are trying to make access to this bioinformatic capability more available, including colleagues here in San Francisco who have developed this open source cloud-based tool for bioinformatic processing. I think there's lots of reasons to be optimistic about the utility of these kinds of tests. The other thing, and I won't dwell too much on this, is that moving forward, One Health needs to be a critical component of how we respond to future pandemics. We know that animal, human, environmental health are fundamentally linked. 60% of infections from humans come from animals. And as you may remember, this outbreak of Nipah virus in Malaysia back 30 years ago was actually from bats that were roosting in pig pens in Malaysia and ended up causing terrible infections in humans. And the bats were roosting in the pig pens because the humans had cut down all the forests where they had been staying. So understanding the interplay between our actions as humanity on biodiversity and its impact for future pandemics is critical. The other thing I'd say, though, and this is highly related, is that if we're serious about ending future pandemics, then we must focus on climate change. The economic costs, not to mention the catastrophic human loss of life from COVID, is a drop in the ocean compared to what we will see from climate change unless we act as a global community to respond to climate change. And this was illustrated this last week in the report to the United Nations by the panel, the Intergovernmental Panel on Climate Change. Their report is very sobering. And let me walk you through some of what they say. So right now, we are already seeing 1.1 degree of increase in global temperatures. I think you're all familiar with this. What you may not be familiar with is how those global increases in temperature are already having an impact. We're already seeing extreme storms like the cyclone in Mozambique that devastated Mozambique's second city in 2018. We're already seeing unprecedented heat waves in places like Pakistan, New Zealand. We're already seeing droughts in Central America and North Africa that are leading to huge migration of peoples who can't farm their land. And here in California, as well as elsewhere in Latin America, wildfires have had devastating implications over the last few years. Right now, 30 million people are being displaced every year from climate change. This is a real problem right now. This isn't a future problem. This is a current problem. And that being said, we know that if we are to prevent future threats from climate change, we need to reduce global temperatures to keep them below 1.5 degrees. We're already at 1.1 degree of global warming. We need to keep them at 1.5 degrees. And if you look at the trajectory on this slide, this is data that was shared this last week, we're trending somewhere towards this middle, this projection here, which some people are calling the middle of the road. This is a 3-degree increase in global warming. Let me tell you why 3 degrees of increase is going to cause devastation. At 3 degrees of global warming, this is 3 degrees by 2100, we will see a rise in sea level that will devastate low-lying countries. We'll see massive species loss, 50% of species lost, and we'll see unimaginable human displacement because of temperature changes, what the United Nations is referring to as a multi-bread basket failure. And just to illustrate how this will play out, this is a slide that shows at 3 degrees of climate change, the yellow on the map is parts of the world that will be inhospitable, uninhabitable for 100 days a year. The red on the map are parts of the planet that will be uninhabitable for 300 days a year. Basically, what we're saying is that all of those places on the planet will not be, will be a death sentence for most parts of the planet. And as I think about climate change, clearly that will have, as I think about climate change, that will have huge implications for future pandemics. It will mean that we'll be seeing emerging infectious disease threats in different parts of the world. But it will also mean that the same populations at greatest risk for climate change are those that are at greatest risk for new emerging threats. And as a consequence, everybody on the planet needs to be paying attention to climate change, particularly people who care about pandemics. I do want to reflect back here that the United States in particular and the global North in general has a major role to play in terms of preventing climate change. We are the main culprit for ongoing CO2 emissions, as illustrated on the right of the screen here in terms of CO2 emissions. And so that requires that folks here in the US need to take the greatest steps if we're serious about addressing this, which in my view is not just an existential threat, it's the primary global health threat of the coming era. Finally, I'll end here. I think to prevent the next pandemic, we need to rethink what we understand by a global response. I think if we've learned anything from COVID, it's that the separation between what happens locally and what happens globally is irrelevant. And as far as COVID is concerned, a new emerging variant in East LA is a problem for Yerevan as much as it is for San Francisco. And so our public health systems around the world need to be better coordinated. We also need to think better about how we deliver care for different diseases. We think that the Omicron variant developed amongst people living with HIV in sub-Saharan Africa who weren't on HIV treatment. And because of their weakened immune systems, the variant was able to develop rapidly. That raises the question of how do we deliver better care for other vulnerable populations, people living with HIV, so that that kind of risk is not perpetuated. And as a consequence, I think we need to think about removing the siloed approach to disease programs. I don't know what your public health system looks like in Armenia, but here in California, we have a TB program, we have an HIV program, we have a COVID program, and I think we need to do better about integrating these disease programs. Finally, I think there needs to be a rethink on global governance for pandemics. And I take encouragement from this paper that was published, an independent panel of experts who recommended that the United Nations needed to invest in a global threat council that could allow the UN to respond quickly to emerging infectious disease threats. Certainly, I think that's the right approach to prevent future pandemics. Almost done. In summary, I think there are compelling evidence that the global incidence of COVID-19 is decreasing. We also have new therapeutics. We have vaccines for children, and we're in a much better place than we were 12 months ago. However, there is no reason to think that a new pandemic isn't just around the corner. And moreover, responding to new infectious disease threats requires more investment in diagnostics, in surveillance, in integrated approaches to care. And the threat of climate change must also impact how we think about future pandemics and how we think about public health programs in general. This could not be a more important time to be involved in public health. I think all of you are in the right. Let me state that again. This could not be a more important time to be engaged in public health because of the future threats that we all face as humanity. Your roles could not be more important. And I love this quote from that Dostoevsky wrote in The Brothers Karamazov. The mystery of human existence lies not in just staying alive, but in finding something to live for. And I think that we are all engaged in the kind of work that has meaning, gives us purpose, and makes life worth living. I will end there, and I'm happy to take questions. Thank you all.